Our third lecture is clinical and lab investigations. In cases of pathology in lacrimal drainage system, we will start with fluorescein disappearance test. The marginal tear strip of both eyes should be examined on the slit lamp prior to any manipulation of the eyelids or installation of topical medications. Many patients with watering do not have obvious overflow of tears but merely show a high meniscus of 0.6 or more versus 0.2 to 0.4 millimeters normally, as shown in the figure here. You can see high tear meniscus, which is stained with the fluorescent. The fluorescein disappearance test is performed by instilling fluorescein 1 or 2% drops into both conjunctival cornices. Normally, little or no dye remains after 5 to 10 minutes. Prolonged retention is indicative of inadequate lacrimal drainage. This should be distinguished from the fluorescein clearance test used to assess tear turnover in dry eyes, in which retained stain is measured in the meniscus 15 minutes after installation of 5 microliters of fluorescein. Afterwards, the next test would be lacrimal irrigation, which should be performed only after ascertaining punctal patency. If absent or severely stenosed, surgical enlargement of punctum may be needed before canalicular or nasolacrimal duct patency can be confirmed. It is contraindicated in acute infection. So the procedure starts with installation of local anesthetic in the conjunctival sac. A punctum dilator is used to enlarge the punctal orifice, as shown in the first picture. This is a punctum dilator. It is used by entering vertically and then tilting the instrument horizontally whilst exerting the lateral tension, as it is shown here in the figure, entering here vertically and then stretching the lid horizontally according to the contour of the canaliculi. A gently curved blunt tip 26 or more commonly 27 gauge lacrimal cannula on a 3 ml saline filled syringe is inserted in the lower punctum, and whilst keeping a gentle stretch laterally on the eyelid, advanced a few millimeters, following the contour of the canaliculus. Now, there can be two outcomes of this test. A hard stop occurs if the cannula enters the lacrimal sac, coming to a stop at the medial wall of the sac, through which can be felt the rigid lacrimal bone. As it is shown here, the cannula has entered the sac, and now a hard stop can be felt. This excludes complete obstruction of the canalicular system. Gentle saline irrigation is then attempted if saline passes to the nose and throat. When it will be tasted by the patient, a patent lacrimal system is present. Although there may still be stenosis, alternatively symptoms may be due to subtle lacrimal pump failure. Failure of saline to reach the throat is indicative of total obstruction of the nasolacrimal duct. In this situation, the lacrimal sac will distend slightly during irrigation, and there will be reflux through both the upper and lower puncta. Regurgitated material can be clear, mucoid, or mucopurulent, depending on the contents of the lacrimal sac. The other outcome can be a soft stop, which is experienced if the cannula stops at or proximal to the junction of the common canaliculus and the lacrimal sac. The sac is thus not entered, as shown here in this picture. So the canaliculi, they are dragged along with the cannula to the sac along the lacrimal bone, and spongy feeling is experienced as the cannula presses the soft tissue of the common canaliculus and the lateral wall against the medial wall of the sac and the lacrimal bone behind it. As a crypt canalicularis with the occlusion of the cannular tip against the canalicular wall can also give this impression, it is worthwhile slightly retracting the tip, increasing the lateral tension on the lid, and gently repeating the attempt to advance the probe. In the case of lower canalicular obstruction, a soft stop will be associated with reflux of the saline through the lower punctum. Reflux through the upper punctum indicates patency of both upper and lower canaliculi, but obstruction of the common canaliculus. The next test on the list is Jones dye testing. Now, dye testing is indicated only in patients with suspected partial obstruction of the drainage system. Epiphora is present, but there is no punctal abnormality, and the patient tastes saline in his or her throat or irrigation. The two parts are the primary test and the secondary test. The primary test differentiates partial obstruction of the lacrimal passages and the lacrimal pump failure from the primary hypersecretion of the tears. A drop of 2% fluorescein is instilled into the conjunctival sac of one eye only. After about 5 minutes, a cotton-tipped bud moistened in local anesthetic is inserted under the inferior turbinate at the nasolacrimal duct opening. The results are interpreted as follows. It's positive if the fluorescein is recovered from the nose and it indicates patency of the drainage system. Watering is due to primary hypersecretion and no further tests are necessary, as it is shown in the figure here. The positive test, the fluorescein enters the whole drainage system and it is then recovered on the cotton bud. On a negative test, no dye is recovered from the nose and indicates a partial obstruction with unknown site or failure of the lacrimal pump mechanism. In this situation, the secondary dye testing is performed immediately. There is a high false negative rate, that is, dye is commonly not recovered, even in the presence of functionally patent drainage system. Modification involves direct observation of the oropharynx using cobalt blue light for up to an hour maybe, and it may reduce the false negative rate almost to zero, as it is shown in the negative testing. Here there is an obstruction and there is nothing recovered on the cotton bud, and here there is obstruction initially at the level of canaliculi and nothing on the cotton tip. Now, the secondary irrigation test identifies lacrimal pump failure or probably the probable site of partial obstruction on the basis of whether the topical fluorescein instilled for the primary test enter the lacrimal sac or not. Now, the topical anesthetic is instilled and any residual fluorescein washed out from the conjunctival fornix. So, the drainage system is then irrigated, and we are not adding any more fluorescein here. We are just draining the lacrimal system. And a cotton bud is then put under the inferior turbinate. It is positive if the fluorescein stained saline recovered from the nose indicates that fluorescein entered the lacrimal sac, thus confirming functional patency of the upper lacrimal passages. Partial obstruction of nasolacrimal duct distal to the sac is inferred, as it is shown in the picture here. As you can see that there is fluorescein here and it is also recovered here, and upon irrigation the partial obstruction is there, but it did enter the lacrimal system and it is recovered on the dye upon irrigation. Now, negative unstained saline recovered from the nose indicates that fluorescein did not enter the lacrimal sac. This implies upper lacrimal, punctum or canalicular dysfunction, which may be due to partial physical occlusion or pump failure. As it is shown here, it can be due to obstruction here, or it can be due to the lacrimal pump failure, which did not let the fluorescein enter the lacrimal drainage system, so there will be nothing recovered on the cotton bud. Next test we are going to discuss is contrast dacryocystography. Dacryocystography involves the injection of radio-opaque contrast medium, which is a thiodized oil, into the canaliculi, followed by capture of magnified images. Indications include confirmation of the precise site of the lacrimal drainage obstruction, to guide surgery and the diagnosis of diverticuli, fistulae, and the filling defects, for example, stones and tumors. It should not be performed in the presence of acute infection. A DCG is unnecessary if the site of obstruction is obvious, for example, regurgitation, mucocele. A normal dacryocystogram in the presence of subjective and objective epiphora suggests failure of the lacrimal pump, though this is more readily demonstrated by a simple irrigation. The figures which are shown here, they present three modalities. The first one is a conventional DCG with radio-opaque material, and we can see that both sides show equal filling here and here. In the second picture, there is a normal left filling, as we can see here. Normal. But there is obstruction at the junction of the right sac and the nasolacrimal duct, and the radio-opaque material is not moving forward. When the digital subtraction BCG is done, it is showing the similar results. The left side has complete filling while the right side shows the obstruction. The next test is nuclear lacrimal scintigraphy. Scintigraphy assesses tear drainage under more physiological conditions than DCG by labeling the tears with a radioactive substance and tracking their progress. Although it does not provide the same detailed anatomical visualization as DCG, it may be used to identify the location of partial or functional block, for example, indicating the absence of significant tear entry to the canaliculi, localizing the site of physiological obstruction to the eyelids to confirm functional obstruction, or sometimes to confirm the presence of normal drainage, such that surgery is not indicated. Now, in this figure, nuclear lacrimal scintigraphy shows passages of tracer via right lacrimal system, as we can see, but the left side is blocked. You can see the right side shows filling, but the left side shows blockage. Now, scintigraphy allows tear drainage to be assessed under physiological conditions and may be helpful to identify the location of a partial or a functional block. In the end, CT and MRI, computed tomography or CT and magnetic resonance imaging are occasionally employed in the assessment of lacrimal obstruction, for instance, in the investigation of paranasal sinuses or suspected lacrimal sac pathology. Internal nasal examination, assessment of the nasal cavity, especially with endoscopy, can be invaluable in detection of obstructions such as nasal polyps or a deviated septum. So we are going to end this lecture with the investigations here, and if you like the lecture, please click on the like button and subscribe to the channel. Thank you all.